present comprehensive care versus comprehensively cared for. A very interesting topic because it does show you can have a multidisciplinary team comprehensively providing care. But really, what does that mean? Lots of examples. So Julian trained in Brisbane, graduated from the Queensland University of Technology with a bachelor's degree in nursing. In his first year as an RN, he headed to New Zealand to work in the, how do you pronounce it, Invercargill Hospital?
Invercargill.
New Zealand, you have plenty of water, if you ever have scarcity in water like we have in New South Wales. The following year, he returned to Brisbane and continued his nursing practice at the Prince Charles Hospital. There he specialised in cardiothoracic nursing and had a deep passion for education and training within the clinical setting. Julian soon found his niche as a clinical facilitator of undergraduate student nurses, continuing on his journey for promoting better bedside care through staff development initiatives. Having just discussed that there's not enough time in other sectors for education. Through staff development, Julian decided to undertake a master's degree in clinical education. He's held positions such as Nurse Education Coordinator, Manager of Education Services, Director of Clinical Services at a private hospital in Brisbane. During his time as the Don, Julian successfully led the team through a full organisation-wide survey against the national standards. Currently works for Quality Improvement Performance Limited, QIP, as National Manager Hospitals and DPS accreditation. Julian is driven to see all people, regardless of race, creed or colour, have appropriate access to individualised exceptional care and treatment where they are included in the decision of their care journey. Welcome, Julian. Thank you.
Thank you. Good afternoon, everybody. How are you? It's always a bit of a hard act, the last session, because everyone's itching to go home or do what they need to do. So I hope that this won't be too boring and that there will be something that you'll be able to get out of it. So thank you, Criterion Conference, for the opportunity to present today. I am still a registered nurse. I am a proud RN. And have been working in the healthcare sector for 12 plus years, both here in Queensland, in New Zealand and here in Queensland. And as you heard, my journey has taken me from clinical education to Director of Nursing, and now I'm in a privileged position to sit on the other side of the fence, which actually wasn't intentional, but it's, it's where I am now, looking after the hospital portfolio at a national perspective for QIP. You're going to have to excuse me a little bit. I've been suffering from this damn chest infection for about 2 weeks now, so just trying to get off the back end of it. So please bear with me and my croakiness. There's my 3 fiery little redheads at the top. My beautiful wife Melissa. That was just last couple of months. We attended a beautiful wedding down at Casuarina. And I thought I would just put some pictures up. In the middle is a photo of our Sydney Children's Network guys who are going through their full accreditation in March next year, which is quite exciting. This is St Andrew's private hospital up in Toowoomba, and again they will be going through their full org-wide assessment against the second edition in March next year. And I just put this little guy here because we went out on an assessment it was a few months back in Alpine. Anybody from Alpine Health? Or that area? Myrtleford? And this little guy, I thought he'd just pop in one day and say good day. So it was just a beautiful location and it was a lovely experience. So, and I too would like to acknowledge the traditional owners and custodians of the land in which we meet today and pay my respects, presenting in front of you, for past, current and emerging leaders, and thank them for all that they are doing and continue to do for our great, beautiful country. So this is what I would like to talk to you about today. I'd like to talk to you about this notion of comprehensive care versus comprehensively cared for. Are they the same thing? how do they differ? And why is it important to treat them separately? And how do we measure the effectiveness of each? And I think in a time like we see today in Australian healthcare, it's a very interesting space. We now have the second edition standards that have landed. We have now a new comprehensive care standard. Does that necessarily mean, or however, that our patients will be more comprehensively cared for? And I think that's just a notion and an idea that I'd like just to put out there for us to have a bit of a think about, and potentially some strategies and in particular a tool that we have developed that may assist hospitals in achieving this idea around understanding comprehensively cared for. So if we just review the timeline of safety and quality in Australia as of today, 1995 Quality in Australia Care Study was published, and in that study it basically said there was 16% of patients in hospitals experienced some form of harm, and they believed back then that 50% of the 16% were preventable. So we're looking at, a ballpark figure of about 8% of admissions in 1995 were preventable, or harm caused, preventable healthcare related harm. So just keep that in the back of your mind for now. That obviously sparked a review in 2005. The National Review of Safety and Quality Governance recommended that accreditation of health services be reformed to enhance quality practices by the bedside as well as the clinical governance. In 2006 we see the COAG, that's the Council of Australian Governments, established Australian Commission on Safety, and to lead and coordinate this effort on delivering national standards to our hospitals. In 2006, we see the health ministers asked the Commission to develop these national standards, and then in 2008 to 2010, the standards were written and consulted, and then we see in 2013 that the standards were then mandated by our health ministers. 2016, they've had a review. They had a review of this, the first edition, as we know, and January this year was the launch of the second edition standard. So that's where we are up to date. So there's a quick snapshot of the timeline of safety and quality in Australia in the last 25 years. Why the revision for the second edition? We'll quickly just touch on, and you would have some thoughts around this as current clinicians, within the healthcare industry. There was duplications of standards. It was seen to be some standards were unclear definitions and open to too much interpretation. It was a bit grey. There was significant investments in clinical audits, which they felt was very costly to the actual hospital or healthcare organisation. The evidence-based literature or research or documentation needed to be updated in terms of its currency. They needed to address this idea around comprehensive care. Patient identification and procedure matching required, there was a bit of overlapping between those, and there was certainly some gaps within mental health, Aboriginal and Torres Strait Islander peoples, and health literacy and end-of-life care. So they're just a few things as to what sort of sparked the revision from an industry point of view. The two major reforms occurred really were about two things occurred: changes to the standard and changes to the process. We see now that they have reduced the duplication in the second edition. We see now that they have incorporated content relating to new and emerging safety and quality issues in terms of evidence-based data. They removed Standard 5, which was the old patient ID. They introduced a new comprehensive care standard, which we've been talking about today, and they removed Standard 8. Changes to the standards in terms of they removed Standard 10, clarified the language and improved the applicability of standards to a broad range of health organisations, not just for hospitals, but now they're looking at MPSs and DPSs, multi-services. They identified primarily that the implementing the actions to the standards would be more streamlined, and they improved the formatting and aid navigation across the different standards. But the largest changes came within the process of how accreditation was to be carried out. And a lot of this change is really to do with the actual accrediting agencies themselves. Had to take a lot of this on board. So the Commission released a document entitled Review of the Australian Health Service Safety and Quality Accreditation Scheme, Improving the Reliability of Health Service Organisation Accreditation Process. And it steps out in that document, if you haven't had a read of it, it steps out 6 strategies that they wanted to implement to improve the changes to the way the process was made and done. 21 sub-action items, such things as standardise the length of assessment, so it's all about the veracity of the assessments themselves. Amend the rating scales. Assessment conducted at short notice. We now have a short notice pathway assessment, which I highly recommend. Actually, I'm a big fan of it. Standardised reporting from the agencies themselves. So a lot of that kind of, in terms of the change of process, is really borne by the health accrediting agencies themselves. Now we have a new national focus, and we know that the comprehensive care is really about driving the reduction of harm to our patients. The very first requirement in the hospital is it should do no harm. The main driver of the new comprehensive care standards was to say, hey, you know what? We want to reduce this likelihood of our patients actually receiving harm and being harmed. But I guess we have to ask ourselves the question, why? I mean, why? What's happening in the Australian healthcare landscape that sparked this new vision to decrease harm in a much more comprehensive way? And I'm not sure if anyone here has read this document. It was released only a few months ago. It's the State of Patient Safety and Quality in Australia Health Hospitals 2009, and it's got some very interesting data over the last 10 or so years that looks specifically at the state of healthcare from first edition to now. And although there are some really positive results within the data, and if you drill in, you get a really good understanding of the true state of it, but there is also some particular trends that are still not going in the right way for Australia, and that is a concern. So some of the positive results are that the total number of sentinel events by year are occurring less frequently. So that's fantastic, and I think a lot of that's got to do with this, attributed to the deteriorating patient programs that we saw come into practice within 2014, 2015, where we're seeing rapid responses now capturing patients before they're actually coding. There was this table was actually in the report, and this is some of the trends that aren't going in the right place. So we see that the hospital-acquired complications generally have increased across the board. Now, this is not about separations. This is not a rate. This is just these are episodes. So you can argue, well, we've had an increased patient admissions from 2014 to 2018, which is correct, and our patient cohorts are aging, and they're coming into hospital with a lot more comorbidities, which is correct, and a lot more complex healthcare needs, which is correct. But some of these figures here, so pressure injury, falls relating in fracture, and VT, and medication complications. These have almost doubled in terms of the actual hospital-acquired complications within care that exceeds the separation rates, if that makes sense. The adverse events in hospitals as well is not trending in the right direction for Australia. We're actually seeing an increase from 2007 to 2016-17 now of adverse events in hospital due to care. And it's expressed here as a rate in terms of a separation. But again, so if we look back in 1995, and And by no means am I saying that this is oranges and oranges comparing in terms of the data, but back in 1995 when they did their first report at the state of the healthcare, they were looking around about 7 to 8% of adverse events, preventable adverse events. This would also highlight that it's slightly decreased from there, but it hasn't moved a great deal. And I think that's some of the concern that we are potentially seeing. And there's multiple reasons for that, but trending up is not necessarily a good thing. That's us here in our home soil. In Canada, they are also experiencing some similar sort of percentages with adverse preventable harm. So, I mean, that's about, and this study was only done over 1 year, and it's a recent study, as in this year was published. They took a cohort for 12 months, and that's at about 6% of preventable injury within hospital due to care. They also have some sort of figures here in terms of money and cost, but I'm a nurse and I don't potentially like to associate costs to patient care, adverse event. I think we should be talking about the effect of the patient and then having a conversation about the cost of the health sector. In America, they've got the Patient Safety Movement Foundation. Has anybody heard of that? Did anybody dress up in orange a couple of weeks back? No? Oh, okay. The QIP team I wasn't at work, but they put all their orange on. These guys have got an ambitious target that they want to see in 2020, zero harm, zero patient harm from preventable injury. And they're saying something like 200,000 patients' deaths, preventable patients' death every year in the US health market. So I'm not quite sure how to play this. Maybe my assistant at the back can help.
Healthy people are dying in hospitals. Every year globally, more than 4.8 million people die from preventable causes. Deaths in hospitals are the third leading cause of death in the U.S., behind heart disease and cancer. And this problem isn't just measured in human lives. The social cost of in-hospital adverse events is estimated to be between 18 and 45 cents of every dollar spent on U.S. healthcare. That means of the $3.5 trillion spent on healthcare in 2017, medical errors account for $1.44 trillion. This all may feel unsettling, but there is hope. We are the Patient Safety Movement, and we've made a commitment to drop the number of patient deaths by preventable causes to zero by 2020 by unifying the healthcare ecosystem and implementing a commitment-based movement, actionable patient safety solutions, and an ecosystem for predictive algorithms through data sharing. We can, together, eliminate preventable deaths and dramatically reduce the cost of healthcare worldwide. Last year, we reported 81,533 lives saved by committed hospitals. And this year, we're excited to report that 90,146 lives have been saved by hospitals that have taken action. And with your help, we can get to zero. But we must act quickly, as we're going to need everyone to lead us to zero. We're going to need policymakers to create incentives for change, healthcare technology companies to sign the Open Data Pledge, and healthcare providers to implement proven processes, such as APSS, to save lives, so that patients survive and families don't have to mourn their loved ones. Your commitment could make all the difference. For her family, his family, their family, and your family. This is more than a mission. It's a commitment-based movement. Commit today so people can live tomorrow.
Well, it's a commendable cause, and I think there's some sobering statistics within all that. But I just wanted to kind of highlight where we currently at, both nationally and internationally. And I'll have to commend the Commission. This new focus on comprehensive care is really about that, is really about saying, okay guys, let's have a very specific focus on how we comprehensively care for our patients within our health services, and get these these trends going in the right direction. But I return to my main question, and this is kind of what I wanted to talk to you about today. Say for instance, if your hospital goes through accreditation and you achieve 36 the action items of the comprehensive care standard, does that translate to your patients being comprehensively cared for? And I know the answer is obvious, and I understand that there's different pockets within a hospital that are performing much better than others, and due to culture, there's pockets of culture and differences. But I think it's this real idea around, this is great and fully commendable by the Commission, but I think that if we solely, in my opinion, if we solely focus on achieving comprehensive care from a standards point of view or an organisation's point of view, then we may be missing the most important thing, and that's from the patient's perspective. So today I'd like to just throw out a notion or a concept for you, that comprehensive care is really from the organisation's point of view. Okay? And just go with me on this. If you don't agree, that's fine. It's simply just a concept, a way of thinking about it differently. Comprehensively cared for is really about from the patient's perspective. So then if we can separate them into those two bubbles, then how do we understand, as clinicians that wake up every morning, that did their training, and that come to work with great intentions to care for and look after the vulnerable and the sick and to do better in people's lives, how then do we understand, how do we know if we are ticking the box of comprehensive care, and how do we know we're ticking the box of comprehensively cared for? And I think it comes back to this idea around patient surveillance data. And in particular, there's so much patient surveillance data, and your hospitals themselves are inundated with patient surveillance data. What I'm really keen on, and what I've got an interest in, is the first one, and that's outcome indicators. And I'll talk a little bit more about that, but basically those three is basically the three indicators that all your health organisations will be capturing and analysing data within one of those three sort of areas. But what I'm really keen on is understanding this idea about outcome indicators. So if I could just get the tech assistant to play this video, please.
When we started, we did about 200 cases a year, which was a lot at that time. Now we do 2,200. We are by far the biggest now in the world. An international problem is that in many, many health systems, as soon as a patient is discharged from the clinic, the clinicians don't know anything about the outcome. In 1992, I started an outcome database motivated primarily for scientific reasons. And I saw the impact of outcome data on our scientific understanding of the disease prostate carcinoma. It's not only important to get your outcome data, they have to be taken by standardized criteria. To have outcome data, I'm very, very sure that the number one who will benefit from it will be the patient. 98% of our patients will recommend that this clinic, after they have been treated here, to their friends or relatives. And I'm also proud about that.
There's been a lot of research into this in terms of patient assessment of outcomes. and has found significant differences between patient and clinician assessment of outcomes, which is contributing to this decline in the notion that the doctor knows best. And I think this is a very interesting space in which we sit now. If we have a look at, cast your mind back to those two bubbles, comprehensive care and comprehensively cared for. If you look at comprehensive care in terms of the indicators that we report as an organisation for our patients, these are some of the things that you're currently doing. And I think there's no issue at all with that. And as a director of nursing at a previous hospital, you know, we used to just every day, every week, every month report and capture, analyse this data. Who looks after palliative care patients here? Okay, so you'd be familiar with Peacock. Who's looking after some rehabilitation patients overnights? And you'd be familiar, you signed up with the Wollongong University for AROC. Yeah, so that's clinician reported outcome indicators, not necessarily by the patients until they go home. And then some of our, you know, our health outcome related performance indicators, which is probably the space that we're all very familiar with: pressure, infection, genital harm, hospital-acquired infections, that sort of thing. Well, this is the stuff that I'm really interested in. I think we do that, we cover that off, and we've got databases, and we've got benchmarking, and we've got indicator programs, and we're all covered off there. I just don't know if we're covered off here. And this is the new space for Australian healthcare that I believe, and this is where I believe that it's going. This is where I believe it needs to go. So in terms of comprehensively cared for, I feel like we're achieving this. We're doing this. Who uses a Press Ganey patient experience survey or something similar to that effect? The Australian Commission have got AQEPs that you can use. It's online, it's been researched, and it's a validated tool. And this is all about asking your patients post-discharge what their experience was. Some hospitals are doing it inpatient experience. Fantastic. Getting the experiences of the patient. But this is the spot here in terms of comprehensively cared for that I think that we need to look at further and potentially start actioning more. Otherwise, we're going to get left behind our international partners. Patient-reported outcome measures. Just a show of hands, who's heard of patient-reported health outcomes? Okay, keep your hand up just keep your hand up, just want to see. Keep your hand up if you are using a PROM-like survey in your hospital at the moment. Okay, two, three? Okay. What, in regards to what, if you can just yell it out, the PROM that you're using, what's it looking at? Uh-huh. And inpatient rehab. Okay, patient reported? Yep. Okay. And you?
Currently 2 prongs in regards to asking the question, their quality of life,
yep.
The outcome of their experience, surgery.
Yep.
The other is identifying based on specialty, disease,
condition.
looking and putting that together.
Excellent.
We use the NESCRIP, so we're one of the Australian sites for NESCRIP follow-up.
Yeah, excellent. So again, show of hands who's using PREMS, who's using a patient experience survey, and a show of hands who's using PROMs. My view is that show of hands in a room this size should be the same in terms of understanding comprehensively cared for from the patient's perspective. So these are some of, and we have developed a tool that can assist organisations, and it's free to use, and I'll talk to you a little bit about a pilot site at the moment that we're trialling it at. But these are some of the PROMs at the moment that are out there. PROMs, they're an emerging method, and the Commission has done a bit of research on this and released a paper last year. Internationally, it's being used a lot, particularly within the NHS, particularly within the US health market, but not a great deal of uptake here in Australia as of yet. Some of the potential benefits for using a patient-reported outcome measure. So patients can be most accurate in describing their own symptoms, pain, function, and quality of life, as you said. PROMs can be used in clinical settings to support shared decision-making and patient-centred care. If you want to achieve, as a healthcare organisation, you want to achieve standard 2, partnering with consumers, showing your assessor workforce team that you've implemented a PROMs survey approach. That's partnering with consumers, that ticks the box. Generate data in terms of treatment effectiveness, adverse events and variations in healthcare and delivery and outcomes. This is published, as you can see, in 2013. The Swedes have been using PROMs in terms of a national database collection. They've got over 100 different databases specifically with PROMs, for the last 20 odd years. So they're moving well with this idea. Fundamentally, there's three types of PROMs, okay? There's generic, disease-specific is what you were referring to, and condition. Disease-specific might be something like prostate cancer. The prostate surgery, they fill out a PROMs, it goes into a database, and they see the outcomes and that gives the surgeons also some very good information too. What I'd like to see is a bit more focus on generic PROMs. And I can explain why. But basically, generic PROMs looks at measuring single or multi-dimensions of health status. And these are some of the examples that are currently out there at the moment. Who's heard of patient activation measures? PAMS. Okay, great. Well, I won't go into it, but basically PAMS is similar to this. It's validated and it's been uptake in the US. It's almost been seen as a sixth vital sign, but I won't go into it, I won't confuse you. At the moment, these are the leading sort of generic PROMs that are out there that are free to use. I found this very, very interesting. This was only published about 3 years ago. This is a hospital in Denmark, and they did a study in their acute admission unit, and they used a generic PROM to report healthcare outcomes measures for their patients. But what they did that was really interesting, as you can see here, is that they had 3 areas: physical function, anxiety, and satisfaction with social role. What they did actually did 3 time points. So they did pre-admission, they did intra, and post. And what they could see was that there would be potentially some differences with the way in which their patients were reporting their health outcomes, dependent upon the journey of their admission. So instead of having an experience survey that you get at the end of your stay and on discharge, and then you sit in a room about a month later and you discuss, did you get the right net promoter score, and is that what the board wants, and thank you very much. It's live data, and they can actually intervene quicker and either pat each other on the back and say job well done, or they can throw some more resources specifically at whatever the problem may be. It gives you a greater awareness and understanding of what exactly is going on within your ward. So that was really interesting to see. So where to from here? And I'm almost finished. I think that we need to start thinking about how we can implement a survey or a tool within our hospitals that incorporates not just PREMs, but also PROMs. And I'll draw your attention to the EQ5D. This is the most widely used generic PROM internationally, hands down, and it's very, very simple. That's it. 5 EQ, because it comes from the group called Euroqual group. 5 dimensions, which is mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. Doesn't matter if it's a pre-cardiac surgical patient, doesn't matter if it's a post-hip, doesn't matter if it's a medical patient, doesn't matter if it's a cystic fibrosis patient, doesn't matter if it's peds, or it doesn't matter if it's neonates or geriatric. It's just those 5 dimensions. And then underneath they've got the 5L, which is no problems all the way to unable extreme. Some great sort of data that they report. And the best thing about that is you don't have to waste your nursing resources on filling out a survey from patients. They do it themselves. So at QIP, what we looked at was saying, okay, what's not in the market? What could we pull from some of this research that we've done and see if we can help and assist our healthcare organisations to better capture both PROMs and PREMs together in a tool, a very simple tool. And in terms of understanding comprehensively cared for, okay? It's all very well and good for comprehensive care, but does that mean it's comprehensively cared for? So we came up with this survey entitled Patient Reported Outcomes and Care Experience Surveys, or the PROCEs survey. And that's it there. That's the question set. That's the bank. So we look at 3 things. We're looking at quality of life indicators. Basically, what's the quality of life of this particular patient? We look at conducting this survey over 3 time points. So we do it on day 1, throughout their admission, and on their last day. Okay, same set of questions. And what we can see is if there's been any changes to their quality of life outcomes, dependent upon the care in which they are receiving or the surgery that they've had. 11 questions, 3 times, or however many times you want, but at least first day, last day, and some time within. Communication, cognition, nutrition, and you would see this and recognise this is very similar to the ADLs, your activities of daily living. Basically, this is quality of life stuff. And then the last question, question 11, is how is your diagnosis or condition or ailment currently affecting your hospitalisation in terms of a rating score? Now, the thing about that is it gives you a score that you can work with, a numerical value, okay, based on what they are saying their outcomes are from the care received. Tacked on to the end is the experience, the PREMs, the experience section of it. So what we can also see then is we can analyse the patient-reported outcome measures, and we can analyse the experience that they had. So you would come to a conclusion that if they've got a great outcome in terms of their quality of life, they've had a great experience. So you would want, typically you'd see both of those at the same level. So the aim of the PROCEs survey is really to assist you guys in saying how to better understand comprehensively cared for. And it's not necessarily to say where you're going wrong. On the flip side, it's almost like, what are you doing good? And we all know that we're doing really good work, but sometimes we just can't put our finger on it. And sometimes we miss the opportunity of giving ourselves and our staff a pat on the back to say, job well done. And this is the evidence that will supply that for you. Better allocate resources and care based on the patient's journey. Used to inform the acuity allocation. We use an acuity tool. Who uses an acuity tool? Trend Care or something like that. Okay, not many of you. Okay. Or ratios. I guess that's kind of like an acuity tool. Promote person-centered care through the patient's voice, engagement with the patient, involving them in their care and their decisions, and engagement with the patients and their family. And it ticks a lot of the boxes also for the national standards too. Increasing the empowerment of patients, assess needs of the patients quicker and more effectively, informing better aligned treatment decisions, prioritising patient provider discussions, monitor, track patient outcomes over time in terms of trends, particularly with some cohorts of patients, medical patients, surgical patients, whatever it may be, and compare with other units and facilities around the country in terms of benchmarking. So how does the scoring work for PROCEs? So basically, as I said, if you look way back here, when they score, at the back end, the survey will spit out a number, okay? So what we have done is that we've kind of flipped it. So we said if they push never, it's a 4, it's high. If they say, I've always had a problem with communication, or I've always had a problem with eating or swallowing, or my cognition, I've got delirium or whatever it may be, it's a low score. So then what happens is that it spits out a score from 0 to 44, basically. If it's 0, they've got a low quality of life score. So this would be some of our palliative care patients in end of life care. If it was 44, that's probably day of discharge. They're just coming for a simple operation or procedure. They're fully independent, they're young, no problems at all. And then what we can do is we can see, well, there can be a tiered approach. So what we can say is that a PROCEs score, a high quality of life score, these patients are fairly good, they're having a great time, okay? These patients, medium score, maybe they need a little bit more nursing resources or medical resources or wherever it may be, allied health. These patients are going to be, needing a lot more. And patients can go up and down this, as we know, but it's about capturing that data and understanding it. So a quick case study, it's very simple, just to highlight that. 65-year-old woman, admitted with pneumonia. She has a Primus PROCEs score, which is day 1 admission of 21. So she's a median quality of life. She's got a chest infection, she's on antibiotics, she's got breathing, mobility, she's 65, whatever it may be. During the admission, she has a 4, but she doesn't break anything, luckily. She just has bruising. They then do her Proctor PROCEs score, which is during her stay, after her 4, and she has a low quality of life score now because she has increased anxiety. She has decreased mobility, which is a lower score. She has no skin tears, but her skin is, an issue and all that sort of stuff. From that, the nursing management and the medical staff, they are aware of that. Her quality of life score has decreased, so now they're going to put in more nursing resources, physio, social work, whatever it may be, socialisation, medical team. And on day of discharge, her FINIS process score jumps up to 32, and it's more than it was when she was admitted, and that's an achievement, and that needs to be celebrated within the team, and that's a pat on the back. Okay, does that kind of make sense in terms of how it sort of works? So bringing it all together, and I've thrown a lot of information at you, but basically we're trying to achieve here, and I hope you agree with me that we safer, better care, and showing you a bit of the data at the start. There's still some little pockets of concern within Australian healthcare in terms of safe care, and that's okay. We just need to be aware of it. I am a big fan of outcome indicators, but done right, and splitting this into two: comprehensive care, which is from the organisation's point of view. I think we're doing this fine. I think this is no problem at all. What I don't want us to do is solely concentrate on this and miss out on this opportunity, if that makes sense. Be blinded almost by, I've got to get all my comprehensive care, 36 action items, all ticked and dusted, so when the assessment team come on board, we're going to get, we're going to meet all those. I think we need to do a little bit more work here and potentially here, and hence why we've developed this tool that you can freely use. So St Andrews in Toowoomba is one of our members. They go through on-site assessment next year. I reached out to them and said, what do you think? And the Don up there, Jamie, who you'll hear in a minute, he was very excited about it. They were using a PROM, only a small amount of numbers within their mental health patients, and they were using it, but not generally and not across the hospital. So they've agreed to sign up as the pilot site, the first pilot site in Queensland, to use the PROCEs survey on 10 medical patients being admitted. So the patients will be all 10 over a course of their journey of admission, however long that may be, depending upon length of stay. But they will be surveyed on day 1, and then they'll be surveyed on day 5, and then day whatever, and then they'll be surveyed again on their day of discharge in terms of their quality life outcomes and their PROCEs score. And Jamie and the medical, Olivia, the nurse unit manager of the medical ward, will be able to quickly see how the quality of life scores are going on that particular ward. So it's quite exciting. So if I could just get the video to be played, thanks, mate.
Hi, Jamie. Thank you for joining me. Just wanted to ask you, what capacity is St Andrews Toowoomba Hospital having utilising PROMs to capture patient care data in the past?
Here we've had fairly limited exposure to standards of PROMs. We do have a fairly light version with our mental health assessment. Nothing really in the medical services field at this stage.
And what is your view of the PROCEs survey? How do you think it will better steer better patient care?
Yeah, look, I think it's a really good initiative. For a while we've been looking at some innovative ways to interact with the clinician and their carers or their relatives in clinical decision making and that sort of thing. So when we heard about this and we came across this, we were quite excited. It can certainly optimise the way patients engage in their care and are involved in their care. It certainly has the potential to improve outcomes and also assist clinicians in measuring how things are going with the patient.
And explain the pilot will be conducted or carried out and what you're hoping to achieve from the trial.
Yeah, look, we've got an enthusiastic and motivated group of nurses that have taken carriage of this quality initiative. So the way that we're planning on going that is led by the nurse unit manager of the medical ward. She's got a couple of champions there who are going to take carriage of it and support probably a cohort of 15 to 20 patients undergoing or access the quality initiative. So the aim is for patients to either on their phones or their iPads to score themselves. So to do it themselves. Those patients where that's not possible, written out on a hard copy on a piece of paper, and the nurses will go through that with individual patients on admission and a few days into their admission, and then on discharge, and then we'll tally them up and we'll monitor from that point of view.
So yeah, it's a really exciting space to sit within because it's potentially a new area, and their pilot begins on Monday. So we're really looking forward to seeing how these results come in, and if it can provide better insight for the medical team and the nursing team in terms of where their resources are going and their care is being provided, and you know, hopefully these patients will be the benefactors of that. So look, I mean, that's basically the talk. Thank you for listening. And again, apologies for my rusty voice, but look, I'll be around tomorrow and hoping to have some conversations about this space. And if anybody else is doing anything in the space, come say hi. I'm really excited about it. And if you're keen to get access to the PROCEs survey, it won't cost anything. It's just, you know, come have a chat with me and we can provide that, and yeah, we can go from there. Thanks.
Have we got any questions for Julian? You've given us so much information.
Everyone's keen to go home.
Well, I suppose I do have one question. In regards to the timing of your survey with your patients, I understand on admission,
Yep.
and then on discharge,
Yep.
but there is a variation
Yes.
of length of stay.
Yeah.
So
It's hard, isn't it?
the
Yeah.
reliability and validity of when do you choose to take that next. You did refer to within 2 days or something,
Yeah.
we'll redo this, but not everyone's
Exactly.
journey
Yeah.
may have different experiences to answer differently.
Yeah.
Interventions or...
And that was the thing that we kind of, you know, when we first started looking at this, that was the main point that we kind of, there's a bit of grey around it. So in talking with St Andrews, we said, look, why don't you determine it in terms of your understanding of the patient cohort on that particular ward, because you know the length of stay is obviously better. And I think I mean, I don't think it's going to be an exact science. I mean, yeah, in a perfect world, I'd love to see it at 5 days and 10 days and 15 days, but I know that, you know, hospital missions don't work like that. But yeah, I don't know if anyone else had any other ideas or how to achieve that. I'm not quite sure, to be honest.
I mean, we currently question our own simplicity that we do have regards to post-discharge. Every patient is sent by email a survey, and within 10 days, I mean, surgical procedures, you know, a lot of them are going to say, no, my quality of life isn't very good at the moment, depending on what they're having done. So I've actually put forward that we need to go further out. And
Yeah.
within 10 days, you're not always going to get the accurate reflection of what you expect at that time.
Well, that's the same with the AROC data. Is it 6 weeks post rehab? Is that right? The post, the functionality, is it 6 weeks post?
I'm not sure. We used to have it and then we stopped it and now we're trying to get it back.
Yeah. So they certainly push it out to 6 weeks post-discharge in terms of your functional increase for that particular reason, I guess. But yeah,
Great. It's an interesting topic to...
Yeah. Thank you. Well, hopefully see you tomorrow.
Okay. Well, coming to the close of day one.